morning and welcome to the final day of the conference. It has been our pleasure hosting you and hope that the conference is proving productive for everyone. In terms of our educational sessions, I'd like to give a big shout out to our Spring Conference Program Committee who has curated a really stellar set of sessions at this particular event. So, yes, bravo. So in the spirit of our conference theme of providing insights into action or otherwise actionable insights, this session highlights the latest trends amidst the evolving dynamics of the skilled nursing sector. This panel will explore critical factors, including workforce challenges, hospital referrals, dynamic operating models, and reimbursement programs that are shaping the current landscape. That's a lot of topics. I imagine some of you might have questions. We will have an opportunity towards the end of the session for you to ask questions, which we'll be orchestrating through our handheld mic. So if you do have a question, raise your hand, and one of my associates will get the mic to you. Our moderator for this panel is Aubrey Hindline, Vice President, Acquisitions and Asset Management with Omega Healthcare Investors. Aubrey also serves as a member of our Future Leaders Council. Thank you, Aubrey.
Thanks, Chuck. I'm going to take a minute to introduce our panelists real quick. So first we have Joe Kiernan. He's the Chief Strategy Officer and Senior Vice President of Network Development for Ocean Healthcare, a network of post-acute healthcare facilities and service lines throughout New Jersey. Joe is responsible for the company's strategic direction, accountable care organization, and preferred provider network relationship development, and bundled payment care initiatives.
Thank you.
Next, we have Gary Blake. Gary is the CEO and co-founder of Creative Solutions in Healthcare, the largest nursing home operator in the state of Texas with over 160 facilities, offering short and long-term care, assisted living, and memory care. A life lived for others is a life worthwhile, has been the foundational principle of Creative Solutions since the company's inception in 2000. And Bernie McGuinness is the president and CEO of Journey Skilled Nursing. Bernie began his career as a certified nursing assistant, has served in numerous positions including licensed practical nurse, facility administrator, and stabilization and turnaround expert. He co-founded Majestic Care and Bluegrass Consulting Group and oversaw their growth throughout over 40 facilities in the Midwest. Bernie and his partners have recently launched Journey Skilled Nursing with a vision to change the world one heart at a time. So our first topic today, we're going to dive into value-based care. Joe, can you please describe the approach Ocean Healthcare has taken to value-based care? What factors into your decision-making when evaluating ACOs, preferred provider networks, and ISNPs?
Okay, so the approach we've taken really, we're sitting in this space of being that post-acute provider. So we're on the receiving end of those value-based care patients and those attributable lives. So we've had to really look at, within the market, which of our referral sources and large-scale physician practices, hospital systems have really engaged in either ACOs or in the bundle payment program. We've seen much of an exit, quite honestly, at least in our space in New Jersey, where we have 12 post-acute facilities. There's been a significant exit from the voluntary BPCI program until mandatories are going to come around, I think, in a couple of years, is what we're hearing. But we've really taken the approach to focus in on our clinical capabilities and also really looking at utilization review to really minimize that length of stay at an appropriate level while at the same time reducing the risk for readmission. Looking at our clinical capabilities within our centers to be able to provide those high-level interactions of stabilizing patients so they don't have to go out to the hospitals for reducing readmissions. And that helps us strategically from the business perspective of being a better partner to our hospitals and to the health systems and the physician practices that have engaged us as a post-acute partner because we have better outcomes. So we really focus in on, you have to have the care first and then you can have the positive outcome. So if we can have those positive outcomes and be a better partner and provide a return for our referral source, theoretically, and we've actually been able to prove this, we actually can pull in more volume because I can raise to the top of that high performance network.
Great, great. So now I'm going to ask Gary a question specific to Texas. So Texas is a bit unique with the Quality Incentive Payment Program, aka QIP, which effectively incentivizes partnerships with hospital systems. How does this impact your approach to value-based care? Can you speak to your partnerships with hospitals outside of the QIP program?
Sure. So it is a complete complement to value-based care because we're scored, like many states, on different metrics. All of those metrics are designed and implemented to improve the patient's life, the family's experience in the nursing home, and certainly increases the quality that we're able to provide system-wide. So it's a statewide program for us. So we're all held to the same standard of the metrics. So you can't get away from it, which is good. You have to deal with it. So that's the biggest compliment because it's already in place, and we're just working to improve it and make it more efficient in our care delivery. And for hospitals outside of the QIP program, that's been a lesson as the evolution of long-term care continues to evolve. For us, our ability to articulate our value to hospital systems, their plans if they own their own network is really important, and we're able to drive key data points to them. Our return to acute is lower. This is how we're participating in this market. This is how we're doing with nosocomial infections. This is how we're doing with pressure wounds. So it actually helps us raise our own standards, and then it raises the standards of how we're viewed in the communities. And that's been lacking. I don't know about other states, but I certainly know in Texas, some of the different companies have made some poor choices in the way they choose to deliver health care. So working with hospital systems and making it right for everyone, we're seeing great outcomes with that.
Great, thank you. And Bernie, what are your expectations for value-based care? What will it look like in the future?
Well, I think long-term care operators need to take a more active role in value-based versus having it dictated to us by payers or by the hospitals. With the emergence of the regional operator model over the last decade versus national, we have that ability now with regional density to go to those local hospitals. Our nursing homes, our skilled facilities, they're a vital part of the healthcare continuum in those local communities. Sometimes you're the largest employer in your county. You're taking the majority of the referrals from that hospital. How do we partner? How do we share some of those healthcare resources? And how do we take the data that we've been collecting now as nursing home operators? How do we empower that and speak in apples to apples language with the hospitals and really understand what they're looking for from outcomes, from metrics? Take our data, speak in their language, and really go about taking some risk. Don't focus on building out your ancillary portfolio as much as building the quality of care and outcomes for your residents, and partnering with those hospitals with the managed care penetration just continuing to rise. We need to have a seat at the table and have a voice and not just have those value-based programs dictated to us, but truly be a partner in those business arrangements. Otherwise, we're going to be, left outside, picking up the scraps from these payers when we're delivering valuable care and we're a necessary part of their healthcare network.
Yep,
Agreed.
Just to follow up on what Bernie just said in the question you asked me earlier, one of the things that we are also really looking at is, the position that we're in is we've got to perform to be able to earn and try to bring those referrals in. That's the only upside for us at this point on the post-acute side. So we're looking at what Bernie was saying, like with the payers and with the hospitals, when is it our turn to receive the the fruits of our labor from being able to reduce that length of stay, to reduce Medicare spending or spending even on the managed care side. So I think the next step in the evolution in this, and Bernie said it perfectly, is let's create our own future. Instead of being told what we're going to be given, let's go out and try to look for, to say, you know, our next strategic step is to go to the payers and say, okay, now where's my check? Because I've been helping everybody else get them. So where's ours?
Yeah, definitely.
Yeah.
Gary, do you have anything to add for what you see in the future?
I see educating our staff more on what it really means to save money for the Medicare system and how it helps the overall. And I think that starts in the recruiting and the retention of our staff, where people are educated and they know they belong somewhere, they will stay there, is what we find. So I think to invest more in the information and the knowledge for your staff is, you just never go wrong doing that. Because then they're drinking the industry Kool-Aid to some effect, but they're helping you produce an outcome, and it's not a force down, it's they reach up for it because you're providing leadership.
And ownership.
And ownership of it, absolutely.
Great.
That's right.
Great. All right, well, we'll move on to our next topic, which is operating models. So Gary, we'll start with you.
Okay.
Creative is the largest operator in the state of Texas with over 160 facilities. You've taken on some large portfolios in the last few years, including some stressed assets that were in need of turnaround post-pandemic. Can you please share some insights into what makes your operating model so dynamic and how you're able to instill your culture and values into newly acquired facilities?
Sure, I'd be happy to. One of the things that we do is it's kind of a saying in our company, in our corporate office, is you hire before you acquire. Because the last thing we want to do is drain our corporate resources to go and tackle 6 or 8 new acquisitions at once. So we hire up knowing that the transition is coming, get people on board, and that way you're not neglecting, you know, your company and the other facilities for these new acquisitions. The other things that we do is we have ambassador programs. So let's say you're acquiring a facility in Dallas, Texas. Well, all of our other Dallas, Texas facilities would sponsor the dietary and the housekeeping. So their peers come in and help them. And then the consultants come in. So they see an enormous amount of help. And with distressed facilities, it's a lack of leadership that got them there, whether it be at the facility level, lack of leadership, or at the corporate level. And I would argue that point until my last day, because leadership counts. And people want to follow something that they can believe in, that they get to see a tangible outcome. They can touch it. They can see a cleaner building. They can see better food. They can see a painted wall. They can see a van that works. It's not sitting on the side of the road. They can see management that looks like management, dresses like management, and speaks like management. And far too many times we flood our industry, whatever industry it is, it can be automobile industry, with people that have a different intention. And I believe that, and I'll wrap up, but one of the things that I think we do different is we kind of state what the problem is, and we state what we're going to do specific department by department. And then we tell them this is what you can expect at the end of a 30, 60, 90, 120-day period. But everybody has to get on board. But if you educate them about what is about to happen, they step up. They absolutely step up.
Great. Joe, do you have anything to add on instilling culture in a new?
We have done the same thing as through our growth. It's not quite as significant as yours. Congratulations, by the way, that's great. As we did, we've acquired, and these were mostly turnaround facilities or even county-owned facilities that were just, financially not strong and, just poorly operated. But so it's through that leadership. And then also, again, I love the idea of using, it's almost a peer-to-peer. So where we brought in and used best practices from within our organization from the folks who practice it on the ground.
Yes.
Management, like you said, looks like a manager, dresses like a manager, talks like a manager. Well, better that they actually look like the director of nursing and talk like the director of nursing, and that's who's going in and working. So that's what we've really done is put peer-to-peer together and say, we're here to help you. And they kind of just relax a little bit, and they do lean in and reach into the process. So that's what we've kind of taken a very similar approach.
Great. Bernie, do you have anything to add?
Yeah, I mean, from a culture standpoint, I think it's a lot of times aligning your incentives and really empowering the role of the leadership in the facility. The administrator has to be aligned with the corporation's goals, and how, as we looked post-pandemic turnover, one factor was the consistency of having the same DON and the same administrator in that building for a year. You had less turnover, less agency use, better survey outcomes. And so how do we ensure that we're investing in those roles so they feel like they want to work for us and that we're the employer of choice? I don't care where you operate. You could operate in San Francisco, Dallas, Texas, or Sandy Hook, Kentucky. You have to have the best administrator and the best director of nursing in those local markets because they're going to know the best staff. Yep. They're going to have the relationship with the survey team. They're going to know the hospital. And how do you connect with those folks and retain those folks and then empower them and give them the tools to do their job by aligning all your incentives? Every corporation usually has pretty good policy and procedure manual, and they have that framework, but that mission is driven out every day by the local leadership.
Well, I'll add to that also to go along with it. There is no way around, if your turnover is high, your quality is low, and you've got to identify and address very quickly in short order and not make excuses why your turnover is so high. And we battle it every day in our company. We have no magic juice and potion or fairy dust to sprinkle on anything. But you can't have high quality and high turnover at the same time.
Definitely. It's foundationally important to operating well is having your staff and your culture really taken care of there. So thank you guys for that. All right, moving on. Bernie, what was unique about your operating model at Majestic Care? As a multi-state operator, how did that impact your approach to post-pandemic issues like ongoing workforce challenges? Is there anything you plan to do differently at Journey?
I want to take what we learned that worked and didn't work, avoid those pitfalls, and continue to expand upon some of the programs that came out the pandemic. When we looked and we were acquiring a lot of buildings, a lot of distressed facilities. I mean, we took over one building and, we had the box of t-shirts and the staff's there to welcome everyone and watch them all clock in at midnight and there's one nurse on staff. Well, it's going to be hard to really impact change when everybody else is agency, right? So we had to figure out what can we do to attract. We got very analytical in our talent acquisition. We expanded our talent acquisition department and started really tracking and trending the way we would referrals. Now, how do we get folks into interview? If they interview, we could close at a higher rate, but how do we get more people to interview than 15% of those applicants? That was a real challenge. So we really started to incentivize our talent acquisition team on conversion and closing, and then align those incentives with our leaders for retention. And then we looked outside of just competitive wages, but how do we get rid of the traditional shift diffs or pickup bonus? No one uses your pickup bonus Monday through Wednesday. They wait till you double it on Thursday because everyone's freaking out they'll have to push a card on the weekend, right? So you might as well just start with that. So how do we say, okay, these things are killing us, working the card all weekend for our DONs, our ADONs, our unit managers, it's burning them out. They have no work-life balance. And we already said without that consistent leadership, you're gonna have turnover. And with that high turnover, you're gonna have poor quality. So really focused on, I think, the benefit side, stickier benefits that I think impact the lives of our care team, whether it was housing discounts in certain markets, communication with free cell phone program, access to telehealth, mental health services that were free, life insurance policies, just discounts, to take their family to the movie if they wanted to. But a lot of different items that we were able to highlight out, move to weekly pay. That's something that as an ownership group at Journey, as a startup, that cash flow, it could be quite a hit, but it's something that we feel is critical to our mission and our vision, and we're gonna take that on. I think it really mattered. And then we aligned some of those old incentive programs with what really mattered the most to us. We need that core group of staff that did show up every day. Every nursing home I've ever been in has a core group. We need that core group to grow. So how do we recognize those folks who come in every single day, who always pick up the extra shift? And then how do we get more people like that on that team? So a lot of perfect attendance incentives to avoid the call-ins, where the stat pays to the agencies, the overtime. It's hard to find someone to pick up 12 hours on a Saturday. That's a pretty hard shift to find. So we really tried to align our incentives and then align our leaders with significant dollars towards agency reduction, their retention of their key leaders, and then take that to the consultant level. So if their administrators don't bonus and you're their vice president, you're not bonusing. We want everybody to be successful and align that all the way up the chain. So we really started an analytical approach to recruiting, stickier, I think, benefits for our frontline staff, listening to their feedback, celebrating the diversity of our workforce, and then aligning those incentives at the facility leadership side.
Great. Just as a follow-up to that, were there any challenges that you found to be unique because you were operating in different states?
Yeah, I mean, there were a couple differences. Housing discount was a real big hit in a couple markets, and then it was a bomb in other markets. We had two facilities, 15 minutes apart, and when we handed out cell phones to the whole staff, one building, they're crying, they're thanking us. In the other building, they won't take it. They assume we bugged them and we're going to track their lives. They're 15 minutes apart, so you try and learn the different personalities of your community, and not everything you do is going to win at every community, but we hoped as a total package that it would work. Each state was a little bit different in how they received those items, and our competitors in each state were a little bit different. Some had some really nice, I think, culture in some of our markets that we were competing with, and others, I think it was a real win for us and a slam dunk in recruiting.
Interesting perspective. All right, Joe. Ocean Healthcare offers an array of product types, including skilled nursing, home health, hospice care, adult daycare, assisted living, acute psychiatric care, and outpatient behavioral health throughout the state of New Jersey. Given the breadth of services Ocean provides, what strategies contribute most to the success of your operating model?
So it always sounds so much larger when somebody else says it, but it doesn't. Sometimes it feels that way during the day too. But it's again, we going back to something that Bernie had said. We grew our core business first, which was our post-acute portfolio, our skilled nursing, and fine-tuned that and really perfected what we do and how we do it. And then we started to really diversify, and that was really based off of looking at what are the needs of that core aspect of our business. So it started out with hospice, and we started from an empty binder and grew that. Hospice got our own license as opposed to acquiring, and it grew into what is now the state's largest hospice provider over the past 12 years. And we are really proud of that. So and our buildings, although we provide significant patient choice as always, but the utilization of our own hospice service within our own buildings went through the roof, and it just made sense. And although that only represents about 10% of our New Jersey-based hospice census is our own buildings, where 90% is the rest of the state, which is where you want it, because we're only so big. We're only going to be able to provide so much opportunity there. So we grew that, and then we started acquiring other and developing our other ancillary programs. So the concept there was to diversify and to not just have to be reliant on the post-acute side of what we do, our skilled nursing facilities. The volatility that was happening with payer changes, with managed care, with labor, those were all factors that kind of came into this fact, saying we need to really look at where else we can invest our dollars and be able to support patient needs and also the needs of our referral sources. So the main model, again, we have all of these verticals, and so if you look at it from that perspective, typically we've seen people, and you work, home care stays in the home care lane, and hospice stays in theirs, and skilled nursing. We broke down those silos, and we said everybody is going to know something about everybody. So we work horizontally across all of those different verticals so that we support each other, and that's that's really what makes it successful. So when we refer to Ocean Health, we refer to it as the Ocean Healthcare Network, and that's why in my title it's Director of Network Development, as opposed to saying Business Development, because it is really what I am doing is developing a network of locations, programs, and services throughout the state. So when we go to our referral sources and other stakeholders who are looking at us and saying, we want to direct our patient population toward you, I can go in and be so much more than just a skilled nursing operator. I can go in and say, well, if that patient's not appropriate for skilled, would they be appropriate for home health? Would you like me to evaluate them for that? Is the family considering palliative care or hospice? We can help you there as well. Joe, never mind, this patient's not going to go to your building. It's more of a behavioral issue. Okay, would you like us to evaluate them for inpatient, an intermediate inpatient psychiatric stay? So we can become a true value-based partner to our referral sources and their stakeholders, the people who are looking at their performance, our performance, and the outcomes. And that has really driven a lot of our success. We're not huge. We're not, we're not in multi-states. I've worked for multi-state companies before, and it was a pleasure. But we've become, we're mid-sized regional providers. But we've become bigger because we offer so much more than just that one business line.
Is it fair to say your referral acceptance rate went way up when you were able to add all those other levels of care?
Yes, because I can plug them into the level of care that patient needs and requires, and what's the most appropriate one. But I would also have to say that my referral volume went up because I had a skilled nursing liaison, so to speak, going to a hospital, and he or she was so much more to that social worker than just a skilled nursing bed. Yeah. Because they could really help them out. And even if they were just like, well, thank you so much, I never even thought to talk to you about that, but then hospice also helps skilled nursing. So when they're out there talking about the skilled nursing buildings, when skilled nursing is out there talking about behavioral health, so everybody's cross-marketing and, again, working horizontally across the whole platform.
Great point. Yeah. All right, so now we'll move on to our third topic, which is reimbursement programs. Bernie, you've operated successfully in a number of different states and continue to evaluate opportunities in states that are new to you. From a reimbursement perspective, what considerations are most important to you when entering a new state?
I think there's two factors from a reimbursement going into every state. The first is Medicaid. You have to understand the state's Medicaid system. You have to understand where they're at, the appetite of that state for rebasing. I'm a proponent of case mix index, capturing the acuity. If you're going to put in service lines, you're going to provide some higher acuity care in these facilities, that there's a track for you as the operator to have reimbursement to keep up with those costs, the training of the staff, the services needed. So you have to really understand state-specific reimbursement. You have to understand, is it a 34 grouper, is it a 57 grouper, 48 grouper? What are they doing? How often do they rebase? When do they move PDPM? Are they going to use NTAs and PDPM? And really make sure that someone on your team understands that and can be an expert. Right? I think, you know, the days of running 40 and 50% skilled mix, those buildings are just limited buildings when you come into states. And rural America happens to be a place we look at a lot of deals. You're not going to run that type of skilled mix. So you have to be a very good Medicaid operator. And if you don't understand state Medicaid reimbursement, then you probably shouldn't go into that state. I think that's the number one factor, is understanding reimbursement at the state level, and making sure that you have a subject matter expert who can help drive that, capture that care. You know, some states you have to go with this accountant firm or that accountant firm because they're just so tied in with the association or with the Medicaid system that they can really be a great asset to you as you enter into a new state. And then the second piece we really look at is the Medicare Advantage penetration. Right? So some states are lagging behind other areas. Even, you know, a state like Ohio, you're going to see, you know, certain markets at 35, 40% penetration, where you're going to get up to Toledo that's closer to 70, 75% Medicare Advantage penetration. So understanding your different markets going in there, because that has to, it gets back to the first question of this regional density, taking control as operators, some of that discussion, and a seat at the table. If you're going to have Medicare Advantage penetration like that, how are you talking to those payers early on? Are you acquiring 4 or 5 buildings? How do you separate those 4 or 5 buildings with defined entry points, clinical niches, and take your 4 or 5 buildings as a network to the payer type and dictate a conversation where you're offering many services? Or are you buying one building that's never going to have a voice in that market? You really have to evaluate that as you look, or, you know, you look at a state that might be going managed Medicaid that's at 40% Medicare Advantage. Well, you know, over the next 5 years, they're going to reach 65, 70% Medicare Advantage. So you can't just rely on their current penetration, but really be able to forecast where they're going as a state. And it kind of helps your strategy, your business development, your network build. How much density do you need in that state to really be effective and have a seat at the table? So I think those 2 factors are the biggest factors as we look at new markets and go into different states. And every state is so unique and so different and comes with its pluses and its minuses. So really trying to evaluate that, you know, outside of all the regulatory side of it all, but this was reimbursement only, so.
You mentioned the state associations. What level of involvement do you typically, once you're operating in a state, have with the association?
Before we even go into the state, I usually call the director of that state and have a conversation about what is the regulatory environment, what's going on, is there some legislation going on, what's the appetite of the local government on Medicaid rebasing, is there rate increases coming? Is there a rate decrease coming? What's the push for homebound services? You know, and I find that the state association directors, they'll take that call, they'll have that conversation, and they're great to work with. And once we go into the state, being very active. You know, I was on the board in Indiana for the last few years and really enjoy the advocacy side, telling the story, having a voice for this profession. But I think it's mission critical to be involved in your state, understand where you're going, and help as a voice. If you're going to have 160 buildings in the state, probably have a voice in directing some of the initiatives that the state association is going to go advocate for.
Great. That leads me right into my question for Gary. You've gotten very involved in lobbying for the industry in the state of Texas. Can you explain why you feel it's important for operators to come together to make their voices heard with the governing bodies within their states, and what impact this has had in Texas?
Sure. So in Texas, we have a healthcare association like all states do, and then we have a coalition that we formed. Both have very specific roles that they play. the association covers the whole gamut, but the coalition we formed just because Texas had gone 10 years without a Medicaid rate increase. And everything was just wrong with that. So we formed the coalition so we would have one voice. You could be a part of the association and still be part of the coalition. There wasn't any animosity between the two or anything like that. But what we realized was the greatest ROI we could get for ourselves and for our residents through a rate increase was to educate state legislators and senators. And some were very open, and obviously some were not, in that we went 10 years without a Medicaid rate increase. But I will tell you, everyone was affected by COVID. So we had received, the state did virtually a $20 a day add-on. So then there was the date that that money would go away and not be part of our daily reimbursement. So we got organized, we got our message, we got a concise message. We urged everyone not to stray from messaging. So they would hear it repeatedly. And we were able to have that $20 a day add-on made permanent. And that was the largest state increase Texas has ever seen in its history. So now we have some different opportunities with COLA, our cost of living adjustment, how that could be part of a Medicaid solution. And we deal with all of the state reps and senators by signing facilities that are in their districts. So they're seeing people in Austin, Texas that are from their district. We invite them to come to our facilities and do a town hall meeting. Surprisingly, some had never been invited to a nursing home for a town hall. And different companies have different ways of managing it, but the overall drive is to drive reimbursement the whole time, talking and preaching about the quality and the increase in quality of life that we're delivering for the patient. The patient is going back to the hospital less. They're not getting a series of tests that are unrelated to what they're in there for. So you show it on a macro and a micro level for them, and they can take it then. But certainly, like I said, the greatest ROI is having the governor, the lieutenant governor, and the senators understanding what your mission is and having some street credit about it, that you're not out there gaming the system, you're trying to sustain the system. Mm-hmm. And it can't be sustained if every Medicaid patient is $1 loss, right? You just can't. So that's how we're doing that.
Yeah, and having a coalition of a group of operators coming with the same message, I'm sure has.
Well, and I'll tell you another way that, getting back to the QIP or in other states, UPL, we really explained how our metrics and how we were driving quality, and they want to be part of a solution. Even at the state level, they still want to be part of the solution. They want that jewel in their crown, right? So we got aggressive with HHSC, my CFO, Chris, other companies in Texas. Listen, we did not do this alone. Every company, from single operators to people the size of Creative or near our size. So what we did is we were able to demonstrate to HHSC that that QIP is valuable, it is needed, and it is getting the outcomes. And they were very interested in that. So in QIP year 8, September the 1st of this year, Texas gets a 60% increase to their QIP dollars. And when we first heard that, I thought they said 16%. Well, I was high-fiving people. I was like, oh my gosh, who gets a 16% increase? But in fact, it was a 60% increase to that. And those dollars are needed, and we're committed to making impacting lives in a positive way and in sustaining the QUIP program for future generations.
Wow.
Yeah, and a great outcome for the efforts you
It is a
have
great
put in.
outcome.
Yeah. Joe, do you have anything to add from Ocean's approach to state associations and how you work with the governing bodies?
Absolutely. So the gentleman brought up great points, and I'm kind of nodding along because we take the same approach, especially with our interaction and engagement with our state association. We're very, very active with them, having been one of our owners and senior managers on the executive committee. Really engaging and stepping up and stepping in to the process so that we have a voice to be able to really influence and show the government and the governor and the lieutenant governor and the senators exactly just how important this is. I love the fact that you also said, about showing them, who's doing this work. What are our residents? They know who our residents are, but meet that CNA. Who needs and deserves to make a living wage.
That's right.
And we're paying that living wage, but we still have to pay that living wage. And I still have to keep the lights on, and I still have to keep the mortgage going, and I have to keep everything going and take care of that person who's dependent on that aid coming to work every day. And so looking at the rebasing and when, understand that this is not, we're not asking for this increase because we don't have enough profits. We're asking for this increase because we want to pay our staff. We want to take care of our residents. So that engagement goes a real long way, and I think bringing out and not just showing up in the suits, but showing up with the scrubs and the lab coats and let them meet the people who are actually doing that work, inviting them to the facilities, taking a tour, and you would be shocked and surprised at how many people have never stepped foot into a nursing home, but yet they are sitting in a legislative meeting making a decision on how much money we're going to get reimbursed to take care of all of those lives. So we're very actively engaged in that in a very positive way. New Jersey has been a good state for us. I've worked in other companies where it's other different states have different models. I think we were also looking at the in terms of the reimbursement different models, and New Jersey's taken a different approaches, but it's worked well for us. And again, I'd say that's probably the biggest part that we've done.
Great. Well, that was just about what I was about to ask you. So how is reimbursement in New Jersey unique? And is there anything you do proactively to manage the Medicare side of it?
Okay, so we were not case mix, then we were case mix, and then they exited out of that because they realized there's a very significantly, we have a high acuity, so that was really driving up that case mix index. So they exited out of that and went back to a more traditional model. So that's kind of what happened on the Medicaid side. On the Medicare side, you just have so much controllables. I mean, your PDPMs are what they are, and it's acuity driven. So we have a very high level of clinical capability within our buildings. We're referred high complexity patients. We do a lot of program development to target high volume patient populations that our health systems are referring to us. So we have cardiac programming, we have pulmonary, stroke, multitude of very specialty programs that will drive more of that Medicare and to a certain extent the managed Medicare population into our centers. Certainly not, and you're right, Bernie, the days of that 30%, Medicare or case mix, those are long gone. I remember those days, but those are gone. And with managed, with the Medicare Advantage plans, really looking at that penetration within markets. You talked about buildings that are 15 minutes apart. I have two buildings 15 minutes apart from each other in northern New Jersey. One has 30 managed care, and the other one 15 minutes away has 4. And they're both in urban markets. And I can't understand the difference why, and it is mind-boggling to me. And very similar patient populations and demographics, socioeconomics, and just And it's across the board. It's not just us. It's other providers those local markets. So we've really looked at how we can bring that population in. But going back to your question with regard to our relationships in shared savings and value-based care, targeting those Medicare lives through ACOs and the bundle payment program. So looking at where that volume is and how many of those patients are being discharged to post-acute settings, and aligning ourselves as high performance network members and preferred providers within ACO organizations, those large scale physician practices where the doctors want to drive, they want that check at the end of the year, and they're going to want a provider who's going to be able to provide them the most upside potential by managing that life appropriately and providing the best level of care at the lowest cost possible. So almost like taking that step back and saying, okay, well, I'm going to take less Medicare money, but I'm going to have more volume because we're doing a better job. So that's really been our overall approach. And then also looking at the diagnoses, and where if I have a higher acuity, it's going to cost me more to care for that patient, but the reimbursement is there. And if I manage those dollars appropriately, it can work out well.
Great. Bernie, do you, either with Majestic Care or with Journey, plan to have any focused, targeted programs that will attract certain types of Medicare residents to your facilities?
I think it'll vary by market. You have to look at your referral hospitals. It'd be silly to build out a pulmonary program if they don't ever discharge pulmonary residents. But you got to go out there, and I think one thing, about building out that network is identifying gaps in care within different networks. Different cities, different hospital systems have gaps in care. It may be hospice, it may be home care, it may be, dialysis in a SNF, it could be ventilator care, it could be memory care services in different markets. So what are those, and how do you meet the needs of that local healthcare community? How do you take your 4 or 5 buildings in a geographic area and meet those needs for the referral sources? We had 4 buildings in Fort Wayne, Indiana, and 1 building, older physical plant, we turned into behavioral building, right? But these were the behavioral residents we're going to take. We're not going to take them over here. We're going to offer veterans here. We're going to have private rehab rooms, hopefully have a little bit higher skilled mix. Here's more traditional long-term care building, memory care services, different things like that. And then here's a building with much higher acuity, some memory care, in-house dialysis, short-term rehab, on-site respiratory therapy. You can really build out different clinical programs and go to the hospitals and say, hey, here's this network, here's some care gaps you have, and people are sitting in your hospital an extra day or two because they're hard to place. We're taking them, right? But we want to be successful. Here's all we can take. We've built out a clinical program around these behavioral residents, and we're taking these folks, and they're very hard to place. But in return, this building needs some short-term rehab, and we offer private rooms, and we're doing a great job, and our return to hospital, and we're willing to use your nurse practitioner group or whatever it is for that continuity of care and good clinical outcomes, avoiding the rehospitalizations. You just really have to identify. I think it would be hard to say what program we're going to focus on as much as, allowing the data to tell us what programs we really need in those markets. And I think it's great. I think Gary had said it a little bit earlier about training the staff. Because when you have a behavioral building, or you have a memory care unit, or you have a high intensity short-term rehab unit doing a lot of pulmonary, you can really do specific training to the staff, and the staff that tend to be a little bit better with a behavioral resident or an Alzheimer's dementia or someone who's really focused on that short term. You can really train on the things they're going to see every day, and you're going to find staff that really embrace that versus trying to mix that all in one unit, and that's where we get staff burnout, and we have some unfortunate incidents when we're with behavioral residents or dementia care residents and an approach of staff. So I really think you've got to listen to your market and meet the needs of it.
Right. For our organization, I think clear conversation with a case manager. What are the hardest to place diagnoses that you have? Include that hospital CEO, because I will tell you, having them understanding the mission, understanding the assignment. I don't want one program in any of our 164 buildings unless there is a need for that program, for that community. We are not going to cookie cutter our programs. In Dallas County, we have dialysis we do dialysis in our facilities. That is a beautiful thing, not driving those fragile patients back and forth in a van 3 days a week in the hot summers in Texas. We have 2 seasons, either you're freezing to death or you're burning to death. And it's uncomfortable to be at someone's mercy like that. And you know, technology is taking us different places. Share with these hospitals how you're using technology, how you're using analytics, how you compare yourself and grade yourself every single day. You know about the discharges. You need to know about the disgruntled families. You need to be the first one. You don't need a call from a case manager saying, this family said I should never refer to you again. Those days need to be over in our industry. And if they're still happening and you don't have a system in place to fix it, and I don't mean put a Band-Aid on it, I mean arrest it. You're not doing the industry any favors. So we have the whole gamut of facilities, older properties and brand new. We just launched a new baby the other day, and an older building can outperform a newer building if the right program is in place. And that's what we're just big proponents of.
Are you able to leverage your density when you think about where you want certain clinical programs?
Yes, so network adequacy is a huge issue, and you hear that a lot in rural markets. We've got to have the access for that Medicaid patient in these markets, and that's the reason for us, we've got so many partners, and Omega is a great partner for us because they participate in urban and in rural, and they have the volume. So then by aligning ourselves with a REIT such as you guys, we're able to have a thumbprint that gets exaggerated, right? So we can take dialysis, hospice, ventilator care in the major metro markets in Texas, and then how it drives and helps us drive the insurance rates and negotiate those rates. And let me tell you, we're not negotiating down, and we're not going to take a discount in an effort to get volume. We're going to get the volume because we deserve the volume. We're going to get the volume because we turn that patient out faster and home better, and better than they went to the hospital, obviously better than they went to the hospital. But we want to make a sustainable change in healthcare, and that is the way you do it. And then you get the reputation for not tolerating that, and they seek you out. And we recently just signed with one of the biggest hospital systems in the state because there were so many gatekeepers, but they kept seeing how our numbers were improving, and our return to acute was, a fraction of some of our other providers. In certain markets, we still have major issues like that, but boy, we hit the sweet spot. So, they said, let's do a blanket contract for 164 nursing facilities. I mean, that's impressive. And we're not going to disappoint them. We're not going to disappoint the hospital system, and we're damn sure not going to disappoint those patients.
That's great. All right, well, Joe, Gary, Bernie, I appreciate you answering all of my questions. We have about 6 minutes left, so we can open it up to questions. I believe there'll be microphones floating around. I can't see out there if anyone is asking anything. Anyone? All right. Okay, I think we're good. Oh, we got Chuck.
Okay. Gentlemen, thank you so much for your expert insights in terms of navigating not only the threats in the market, but also the opportunities for skilled nursing, which certainly remains an essential and critical option for older adults as it relates to their care going forward. So we welcome your input on our session. Please provide that via either the QR codes on the screens or the kiosks in the back. This will be our final break of the conference. It'll be only 15 minutes, although now actually, well, nearly 20 minutes. At 9:45 is our final session. It's the Capital Markets and Economics update, and it features Doug Duncan, who is the chief economist for Fannie Mae. So we hope to see you back here at 9:45 for the final session. And again, thank you to our panel.